Welcome to Deep Dive Ortho. Imagine that scenario, the one we all dread. A patient suffers a fracture, they go through the pain, the surgery, the long weeks, sometimes months of recovery, only for that bone to stubbornly refuse to heal. Now, this isn't just a medical setback, is it? It's a really profound challenge to a patient's life, their function, their well-being, and frankly, a significant burden on our healthcare systems. Today, we're plunging right into that very scenario, bone non-union. We're going to try and unravel why this happens, and perhaps more importantly, how we as clinicians are fighting back with the latest science and, crucially, a truly multidisciplinary approach.
That's right. It's a persistent problem in orthopedics.
Joining us to navigate this incredibly intricate and, let's be honest, often frustrating landscape is Professor Mo Imam. Professor Imam is a leading authority in orthopedic and trauma surgery, really renowned for his ability to synthesize complex information into actionable insights for us, the clinicians on the front lines. Our mission in this deep dive is to unpack the very latest understanding of bone non-union. We'll look at everything from its fundamental definitions, which seem a bit murky, and the myriad underlying causes, right through to cutting-edge treatment strategies and the absolutely crucial role of the interprofessional team.
Yes, we'll delve into recent data, explore the clinical implications, and really discuss what all of this means for you in your daily practice when you're faced with a non-union.
Right. Professor, it seems we can't even get out of the starting blocks with non-union without hitting this fundamental snag, actually defining it. I've seen so many interpretations out there, different timelines, different criteria bandied about. What's the common ground, or is there any? Where do we even begin with a robust, clinically useful definition?
That's a very perceptive opening, actually, because this definitional challenge is, well, it's a significant point of contention within the orthopedic community. Historically, and still very widely cited, we often refer back to the U.S. Food and Drug Administration, the FDA, definition from way back in 1998. They pragmatically defined a non-union as a fracture that persists for a minimum of 9 months without any discernible signs of healing for at least 3 consecutive months within that period. It's sort of been our benchmark for decades, hasn't it?
9 months, 3 months. Okay.
However, while it provides a necessary starting point, it's also quite a loose and, frankly, somewhat arbitrary definition when you consider the vast biological variability, not just between different bones, but different patients, too.
Right, not every bone behaves the same way.
Exactly. Think about a scaphoid fracture in the wrist, notorious for slow healing, often needing longer immobilization versus, say, a simple metatarsal fracture. Their healing trajectories are vastly different. And then you have external factors playing a huge role. We've seen compelling evidence that certain medications, like long-term bisphosphonate use, can significantly affect healing times, often leading to what we call atypical femur fractures.
Ah, yes, the AFFs.
Precisely. Adigan and colleagues, for instance, have shown that delayed unions, which we generally define as fractures failing to reach bony union by 6 months, occur much more frequently in these atypical femur fractures. So while the FDA definition is a useful rule of thumb, it's certainly not a one-size-fits-all criterion. It doesn't capture the biological complexity we encounter day to day.
That's a crucial distinction, Professor, and you've hit on something that I think many of us grapple with. If the formal definitions are a bit loose, what does that mean in practice? When different clinicians might have different thresholds or criteria, it sounds like it could lead to inconsistencies in diagnosis and, well, consequently in management too. How do you navigate that variability?
You're spot on. That lack of universal consensus in the orthopedic literature regarding a precise definition, especially for long bone non-unions, despite years of research, it remains a major hurdle. A recent scoping review highlighted this quite starkly. It found that a staggering 50% of relevant studies didn't even provide a clear definition for non-union.
50%, that's remarkable.
It is. And among those that did, there was significant heterogeneity in the time-related criteria, ranging anywhere from 3 months right up to 12 months. This inherent variability makes it incredibly difficult to compare study outcomes, to interpret research effectively, and even to standardize clinical guidelines.
So what's the alternative, a more practical approach?
Well, to address this pragmatic challenge, a more clinically oriented interpretation is often adopted. You see this particularly in Northern European trauma societies, like the Danish Orthopedic Trauma Society. They define non-union more functionally as a fracture that will not heal without further intervention.
Ah, okay. That shifts the focus.
Exactly. It shifts the focus from a strict, somewhat rigid timeline to a clinical reality, that point where you, as the surgeon, make a judgment call based on multiple factors that this particular bone is stuck, it needs help. But of course, the ongoing challenge then becomes, how do you definitively characterize the clinical and radiological signs that lead you to that conclusion? It also brings up the important practical distinction between a true non-union and what we term a delayed union.
Right, the 6-month mark you mentioned.
Generally, yes. A delayed union is understood as a fracture that has simply failed to reach bony union by about 6 months. The implication there is that it might still heal, perhaps with more time, a bit more protection, or maybe less aggressive intervention. Whereas a true non-union has essentially declared its biological and mechanical inability to heal without a significant intervention.
Okay, so moving beyond just the timeline, which, as you've highlighted, can be quite elastic, what are the definitive clinical and radiographic signs? The things that truly indicate a non-union. What are those smoking guns you look for in clinic or on the x-ray that tell you, right, this fracture won't heal without me stepping in?
Excellent question. These are the crucial markers we rely upon daily when assessing a patient. Radiographically, the key indicators are a clear, persistent lack of cortical bridging across the fracture lines.
You just don't see the bone joining up.
Precisely. You don't see that progressive formation of new bone uniting the fragments across the gap. Or there might be a persistent, discernible gap at the fracture site itself, even after many months. In some cases, you might even see sclerotic, hardened bone ends, which really indicates a biological stalemate the bone's tried, but instead of healing, it's just hardened its edges.
And clinically, what does the patient report, or what do you find on examination?
Clinically, it's perhaps even more telling, and something you'll often feel in your hands. Normally, after the acute phase, a healing fracture means a gradual resolution of pain, especially with weight bearing, and crucially, no abnormal movement at the fracture site on examination. With a non-union, however, patients almost invariably report persistent pain at the site of the break. This isn't just residual aches. It's often a deep, constant, or activity-triggered pain that's lasted for many months, sometimes even years, long after the initial fracture pain should have gone.
Pain with weight bearing is key then.
Very often, yes. It might be present even at rest, but it frequently intensifies with any attempt to bear weight or use the affected limb. And critically, upon meticulous physical examination, you will frequently detect abnormal mobility at the fracture site.
You can actually feel it move.
Yes. When you gently stress the limb, you can feel that the fragments are still moving independently. That indicates a clear failure of structural integrity. This combination, chronic, persistent pain and demonstrable motion at the fracture site, is, in essence, the clinical hallmark of a non-union. It signals that the biological bridge has failed to form.
Building on that, Professor, once we suspect a non-union, the next crucial step is understanding what kind it is. It's not just that it didn't heal, but why it didn't heal and what that looks like on imaging. This understanding is absolutely critical for effective management, isn't it? Could you walk us through the primary classifications and what they tell us about the underlying problem?
Absolutely. Classification is fundamental because it directly guides our treatment approach. It essentially provides a diagnostic roadmap. One of the most widely accepted and clinically useful systems, which has really stood the test of time, is the Weber and Seck classification from 1976. This system primarily assesses the vitality and biological reactivity of the non-union, largely based on its radiographic appearance. It divides non-unions into categories that reflect their underlying biological state and, critically, point us towards the likely cause of failure.
Okay, so what are the main types?
Firstly, we have hypertrophic non-union. This type is characterized radiographically by abundant callus formation. You see a lot of new bone trying vigorously to form. It's often described as an elephant's foot due to its bulky, exuberant appearance at the fracture ends.
Lots of biology, but no union.
Exactly. Despite all this biological activity, there's no bridging bone. The ends are not united across the fracture gap. The implication here is profound. There's adequate blood supply and good biological activity. The bone wants to heal. It's reacting, forming callus. The fundamental problem, therefore, is inadequate mechanical stability.
Too much movement.
Precisely. The fragments are moving too much, often due to insufficient or failed fixation, preventing that immature callus from bridging and maturing into solid bone. For these cases, our treatment almost exclusively focuses on improving that mechanical environment. More stability is needed.
Right. And the opposite end of the spectrum.
That would be atrophic non-union. This is in stark contrast. Radiographically, these show absent or minimal callus formation. The bone ends often appear tapered, atrophied, sometimes described as looking like a horse's hoof, indicating a severe lack of biological activity.
So poor biology.
Yes, this appearance directly implies poor biology. often due to insufficient blood supply, perhaps significant soft tissue damage, or other systemic factors inhibiting the bone's ability to respond. And usually, this is combined with a lack of adequate fixation as well. Here, the bone isn't even trying to heal effectively. The biological engine has stalled.
So treatment needs to address both.
Exactly. Treatment for atrophic nonunions must address both the biological deficit, adding graft or stimulants, and, crucially, establish robust mechanical stability.
Okay. Are there others?
Yes. Next, we have oligotrophic nonunion. This category represents a kind of balance or combination between the two extremes. It shows incomplete callus formation radiographically. It often indicates that while there might be some biological activity, there's perhaps been inadequate reduction or significant displacement of the fracture fragments, hindering the healing process. So it's often a mix of mechanical and biological issues that need addressing, perhaps leaning more towards the mechanical side if the biology is still somewhat active.
A bit of both worlds.
Sort of, yes. And finally, and perhaps the most challenging, is septic nonunion. This is a critical category because it's caused by infection at the fracture site.
Infection complicates everything.
Profoundly. The presence of pathogenic organisms consumes essential nutrients, significantly reduces local blood flow, and releases inflammatory mediators and enzymes that directly inhibit new bone formation. This type adds a formidable layer of complexity to treatment. Infection eradication becomes the paramount first step before any meaningful bone healing can even be considered.
You have to clear the infection first.
Absolutely. Without rigorously controlling the infection, successful bone healing is highly unlikely, regardless of how robust your fixation or biological augmentation might be. Each of these classifications provides a crucial roadmap for determining the most appropriate and effective treatment strategy for you and your patient.
Professor, that's a brilliant way to break down the types, and it immediately points us towards the right treatment path. Now, if defining it is tricky, and classifying it tells us what type of problem we're dealing with, then we have to ask, who is most vulnerable to this frustrating outcome? Professor, when a patient walks into our clinic, what are the absolute red flags screaming high risk of nonunion that we should be looking out for beyond the fracture itself?
Yes, the million-dollar question, isn't it? Because identifying risk factors up front can actually guide our primary fracture management, potentially helping us prevent nonunion in the first place.
Yeah.
The prevalence is quite significant. It poses a substantial burden. In the United States alone, an estimated 100,000 fractures progress to nonunion annually. Across all fracture types, the rates generally range from maybe 1.9% up to 10%.
That's a wide range.
It is, and it varies considerably based on anatomical location and the injury characteristics. For instance, femoral shaft nonunions are estimated at about 8% with standard intramedullary nailing, while tibial shaft rates can range from 4.6% up to maybe 10-12% in some studies. What's also very clear is the profound impact of soft tissue damage. Open fractures, especially those with extensive compromise, can see nonunion rates climb significantly, sometimes reaching a staggering 16%.
So the injury itself is a major factor. What about the patient?
Absolutely. When considering individual patients, there are several crucial patient-specific and fracture-related risk factors, those red flags you mentioned, that we should be acutely aware of. Based on large-scale studies like the one by Steen and colleagues, most important patient factors are, unequivocally, smoking and diabetes.
The usual suspects, unfortunately.
They really are. Smoking, for example, is a deeply entrenched modifiable risk factor. We know it significantly reduces vascular supply through vasoconstriction and impairing endothelial cell function. It directly affects osteoblast activity, the very cells that lay down new bone, and it's linked to higher parathyroid hormone levels and vitamin D insufficiency, further hindering bone metabolism.
And diabetes.
Similarly, diabetes, even if seemingly well controlled, can profoundly impact healing. It decreases collagen production in the callus, impairs osteoblast function, and reduces the number of mesenchymal stem cells needed for repair. It's a systemic metabolic issue that affects every tissue, including bone.
Okay, smoking and diabetes are key. What else?
Injury severity is another major determinant. As I mentioned, open fractures where there's direct communication with the outside environment have a much higher nonunion rate, maybe 10.9% compared to 4.7% for closed fractures.
Because of contamination and tissue damage.
It's exactly. Greater energy dissipation, more soft tissue damage, higher risk of infection. Also, the number of concurrent fractures escalates the risk dramatically. A patient with 7 or more fractures faces maybe a 24% nonunion rate, vastly higher than the 4.4% for a single fracture. High-energy trauma mechanisms lead to less robust hematoma formation and more extensive soft tissue injury and devascularization, further compromising that crucial healing environment.
What about medications? You mentioned bisphosphonates earlier.
Yes, medication use plays a significant and perhaps sometimes underappreciated role. It's particularly concerning to note the strong association of non-steroidal anti-inflammatory drugs, NSAIDs, combined with opioids for pain management. One study showed a multivariate odds ratio of 1.84 for non-union with that combination.
That's quite high.
It is. Opioids alone and anticonvulsants with or without benzodiazepines are also identified as positive risk factors. It's a nuanced point with NSAIDs, though. While short-term use for acute pain relief, say post-op, might not significantly delay healing, long-term use is definitely linked to increased non-union risk.
Why is that?
Because they inhibit prostaglandin production, which is vital for the inflammatory phase of healing and for osteoblastic activity. So managing pain effectively without compromising healing becomes a delicate balancing act for us.
Right. What about other comorbidities?
Looking at comorbidities, several stand out clearly in the data. Osteoarthritis alone increases the odds, or about 1.45, and even more so when combined with rheumatoid arthritis, or 1.58, likely due to systemic inflammation and perhaps medication side effects. Type 1 diabetes, or 1.40, is also a strong predictor due to its microvascular complications and metabolic dysregulation. Other conditions like obesity, or 1.19, vitamin D deficiency, or 1.14, which is incredibly common, renal insufficiency, or 1.11, and osteoporosis, or 1.24, along with its medication use, or 1.17, all elevate the risk.
And osteoporosis affects the bone quality itself.
Exactly. With osteoporosis, we see reduced osteoblast production and poorer bone quality, which directly impacts callus formation and the bone's intrinsic ability to heal. Severe anemia and hypothyroidism are also implicated as they affect cellular metabolism and oxygen delivery.
Are there biological factors specific to the fracture site?
Absolutely. Crucial biological factors include anything that leads to reduced blood supply to the fracture fragments. Poor nutrition, peripheral vascular disease, or simply the nature of the injury itself. These starve the healing process of essential nutrients and oxygen. A lack of cortical continuity where the bone ends aren't properly touching also makes healing challenging. And certain bones are inherently more prone due to their limited or watershed blood supply, making them susceptible to a vascular necrosis and non-union if injured. Think of the scaphoid, the talus, the femoral neck, classic examples where healing is notoriously difficult because of poor vascularity. These are the avascular watershed areas.
Mechanical factors too, presumably, like the hypertrophic type suggested.
Yes, mechanical factors are equally important. Inadequate fracture fixation or stabilization leading to excessive movement at the fracture site is a common culprit. Large fracture gaps, particularly those greater than 3 millimeters, and certainly anything above 6 millimeters where you rarely see callus form without significant help, highly comminuted fractures, and excessive interfragmentary movement, high IFM, large gaps, high tissue strain, transverse shearing, all compromise healing. Malalignment that requires surgical revision or perhaps even poor initial surgical technique can also contribute.
Then infection again.
And, of course, infection remains a major contributing factor, especially in open fractures or following any open surgery. An infection at the fracture site devours nutrients, generates damaging byproducts, and reduces crucial blood flow, severely hampering new bone formation. It's a disaster for healing.
Any demographic patterns?
Lastly, it's worth noting some interesting findings regarding demographics. While women experience more fractures overall, one large study indicated that male gender, or 1.21, showed a slightly higher proportion of non-unions, perhaps due to higher energy trauma patterns or different comorbidity profiles. Interestingly, that same large study indicated a slight inverse correlation with age, an odds ratio of 0.97 per 10 years increase for the overall cohort, particularly noted in bones like the radius and scaphoid.
That's counterintuitive. Usually we think older patients heal slower.
It can seem that way, yes, and other literature often cites older age as a general risk factor for delayed healing. However, children definitely demonstrate faster and more robust healing due to superior vascularity and a thicker, more active periosteum rich in osteoblasts. This specific finding on age perhaps highlights the sheer complexity and the sometimes varying findings we encounter in the epidemiological data. It really underscores the need for a truly comprehensive, patient-specific risk assessment for every individual. We can't just assume older patients always heal slower in every scenario.
That's a truly comprehensive list of risk factors, Professor, and it certainly gives us a lot to consider in our preoperative planning and patient counseling. So given all of them, What exactly is going wrong at the cellular and molecular level? What prevents a bone from healing? What's the why behind this dysregulation, or as you put it earlier, the stalled construction project?
That's precisely the crux of the pathophysiology, isn't it? Where we delve into the why behind the failure. Normally, bone healing is a remarkably orchestrated cascade of physiological processes, often likened to a meticulously planned construction project. After a fracture, the first critical step is hematoma formation. This acts as a scaffold and contains platelets and macrophages. These cells immediately kickstart the inflammatory response, releasing a host of signals.
So inflammation is actually good initially.
Absolutely. This initial inflammation, far from being purely destructive, is crucial. It sets the stage for repair, leading to the rapid recruitment of mesenchymal stem cells, or MSCs, to the fracture site.
The MSCs are key then.
They are the key cellular players, the master builders, if you will. Depending on the local environment, things like oxygen tension and mechanical stability, they differentiate into osteoblasts, which are responsible for secreting bony matrix and inducing mineralization, effectively depositing new bone. They also differentiate into chondrocytes, which form a cartilage template that later ossifies in a process called endochondral ossification. As healing progresses, a critical balance is then needed between osteoclast-driven callus resorption, demolition crew breaking down immature bone and necrotic tissue, and osteoblast-driven lamellar bone deposition, which builds stronger, organized bone. It's a dynamic, constant remodeling.
And what controls all that?
At the molecular level, this entire intricate process is mediated by an array of powerful growth factors and cytokines. Think of them as the cellular messengers or the blueprints and instructions. Platelet-derived growth factor, PDGF, fibroblast growth factor, FGF, transforming growth factor beta, TGFA, insulin-like growth factor, IGF, and especially the bone morphogenetic proteins, BMPs, particularly BMP2, 4, 6, and 7, are absolutely essential. They stimulate cell proliferation, differentiation, and the synthesis of the extracellular matrix, effectively telling the cells what to do and how to build. Cytokines like interleukin-1, IL-1, IL-6, and tumor necrosis factor alpha, TNF-A, also play a vital role in initiating and regulating the inflammatory response and stimulating MSC migration.
And vascularity, you mentioned that earlier.
Crucial to all of this, yes, is vascularity. The formation of new blood vessels, neoangiogenesis, is non-negotiable. This process is largely mediated by vascular endothelial growth factor, VEGF, and its intricate interactions with BMPs. A deficient supply of nutrients and oxygen to the fracture site, perhaps due to a high-energy injury or poor systemic health, is a primary driver of nonunion. It directly impairs the activity of all these cellular and molecular players. Without that lifeline of blood, the construction project simply runs out of materials and energy. In essence, nonunion represents a profound and often multifactorial dysregulation of this beautifully intricate normal bone healing process. It's when one or more critical steps in this biological orchestra go silent or just out of tune.
Professor, that detailed explanation of the cellular and molecular dance truly illuminates the why. And this concept, the diamond concept, seems to tie it all together beautifully. It sounds like a holistic framework for understanding not just the problem, but also pointing us towards the solution. Could you walk us through it, perhaps illustrating how it helps a clinician immediately identify the missing link?
The diamond concept is indeed a truly comprehensive and I think elegant framework for understanding the essential requirements for successful bone healing. It's become an indispensable tool in our practice, really moving beyond a simple checklist to a deeper understanding of the interwoven components. It gives equal importance to both the biological and the mechanical environments, identifying 6 critical pillars that must be adequately present and optimized for a fracture to heal. Crucially, a deficit in any of these components significantly increases the probability of nonunion, and identifying which pillar is deficient directly guides our treatment strategy.
6 pillars. Okay, what are they?
Right, let's break them down and you'll see how they all connect. First, osteoinductive mediators. These are the chemical signals, the start buttons, that stimulate progenitor cells to differentiate into bone-forming cells. They're primarily cytokines, released from platelets and macrophages in the fracture hematoma, the body's natural first responders, and crucial growth factors like PDGF, FGF, IGF, and especially the BMPs, particularly BMP2, 4, 6, and 7.
The signaling molecules.
Exactly. Without these specific signals, the cells don't get the message to start making bone, no matter how many cells are present. In a non-union, we might augment this with exogenous BMPs, or perhaps concentrated growth factors from PRP. Second, osteogenic cells. These are the actual bone-forming cells themselves, the builders. We need a robust supply and activation of osteoprogenitor cells from the periosteum, as well as undifferentiated multipotent stem cells, MSCs, from the bone marrow and endothelial progenitor cells. These are the living bricks and mortar of new bone.
So you need the cells themselves.
You do. If a patient's bone marrow is depleted, perhaps due to age or treatment, or the injury has destroyed local cells, we might need to introduce them, for example, via autologous bone graft or bone marrow aspirate concentrate, BMAC. Third, extracellular osteoconductive matrix, scaffold. This is the physical framework, the construction site, upon which new bone can grow. It acts as a scaffold for cell migration and adhesion.
Something for the cells to grow onto.
Precisely. In a fresh fracture, the necrotic bone at the site can serve this purpose initially. But in a non-union, this natural scaffold might be resorbed or inadequate. So we often need to provide this artificially, perhaps with autographed, demineralized bone matrix, DBM, which also retains some osteoinductive capability or synthetic bone graft substitutes. It provides the physical template. Fourth, optimum mechanical environment. This is perhaps one of the most frequently overlooked or misunderstood components, yet it's absolutely critical. It refers to the concept of strain and micromotion at the fracture site.
Not too much, not too little movement.
It's exactly that. Low strain promotes intramembranous ossification direct bone healing. Moderate strain encourages endochondral ossification, indirect healing via cartilage. The critical point is that too high a strain, or a very large fracture gap, say greater than 6 millimeter, can lead to non-union because the tissues become too stressed or too mobile to ossify effectively. We need just the right amount of stability and motion. This is where robust internal or external fixation comes in. Fifth, adequate vascularity. This is absolutely essential, the lifeline delivering oxygen and nutrients. As we discussed, high energy and open fractures are notorious for compromising this critical vascularity, which then starves the entire healing process.
If the blood supply is gone.
Then even perfect fixation and abundant cells won't achieve union. This is where techniques like vascularized bone grafts become incredibly valuable, bringing their own blood supply. And sixth, addressing host comorbidities. Finally, this pillar acknowledges that the patient isn't just a fractured bone. They are a whole complex physiological system. Systemic factors like diabetes, smoking, poor nutrition, osteoporosis, renal insufficiency, chronic inflammation, they must be addressed and optimized. Their overall physiological state is integral to the bone's ability to heal.
Treating the whole patient, not just the fracture.
Precisely. If the patient is malnourished, severely vitamin D deficient, or has uncontrolled diabetes, the best surgery in the world might still fail. What's also fascinating here is that the diamond concept incorporates the idea of a biological chamber. This refers to the necessity of containing any biological enhancements, graft, growth factors, precisely at the non-union site. You're essentially creating a local bioreactor to ensure maximum effect and prevent dispersal.
Keep everything where it needs to be.
Exactly. And when all 6 of these principles are rigorously applied, when you systematically identify and address the deficiencies in each pillar, we see dramatically improved union rates. It really works.
That's a truly brilliant framework for understanding the why and guiding the how. Now, turning to clinical practice, with all these complex factors and the challenges we discussed around definition, how do we as clinicians accurately diagnose non-union? What's your systematic approach in clinic?
Diagnosing non-union requires a comprehensive and thorough evaluation, precisely because it's so multifactorial. We really need to piece together the entire clinical picture to form an accurate diagnosis and then, crucially, to understand why it's not healing for that particular patient. We always start with the detailed patient history. This is absolutely essential. We need to understand the initial injury mechanism, high energy, open, closed, what previous surgical treatments have they had, or IF, IMN. Then, we delve deeply into systemic risk factors, nutritional status, smoking history, diabetes and its control, vascular disease, vitamin D status, renal function, current NSAID or steroid use. And we need to elicit the characteristics of their pain at the fracture site. Is it constant? Worse with activity, only with weight bearing. How long has it persisted?
The history flags up potential issues.
Exactly. A patient telling you they've had continuous pain at the fracture site for 8 months and it still feels unstable, that's raising a huge red flag right there. Following the history, a meticulous physical examination is paramount. Key elements include assessing for any overt signs of infection, draining sinus tracts, purulence, localized erythema, warmth. A comprehensive neurovascular check is standard, as is evaluating the soft tissue envelope's integrity, scarring, and poor coverage can impede healing. But most importantly, and often the most definitive clinical criterion, is assessing for any mobility at the fracture site. If you can detect abnormal, non-physiological movement upon gently stressing the limb, that's a very strong indicator of failed union. Not just crepitus, but actual gross motion between the fragments.
Okay, history and examination are key. What about imaging?
In terms of imaging modalities, plain radiographs remain the initial cornerstone, usually two orthogonal views, AP and lateral, to get a foundational look. For objective assessment, particularly in long bones like the tibia, we often use the RUST score, the radiographic union score for tibia. This ranges from 4, no callus on any cortex, to 16, complete remodeling. It provides a quantifiable measure of healing progression, or lack thereof.
Scoring each cortex.
Yes, each of the 4 cortices is scored separately. 1 for no callus, 2 for callus present, 3 for bridging callus, and 4 for full bridging with remodeling and no visible line. It helps track things over time.
And if the x-rays aren't clear?
If radiographic union is equivocal, or if we suspect an occult gap, we then recommend computed tomography, CT scans. CT offers high-resolution multiplanar views and is invaluable for evaluating bridging callus, especially in later stages. It lets us see the 3D architecture.
Even with metalwork in place?
Yes. While metallic hardware can create artifact, modern CT scanners and software algorithms are much better at reducing this. It often provides crucial detail plain films miss, helping us accurately assess the degree of union. Magnetic resonance imaging, MRI, isn't typically the first choice for assessing bone union itself due to bone signal and hardware issues, but it's incredibly valuable for looking at the soft tissues detecting deep collections, atypical inflammation, or sinus tracts that might suggest occult infection. It also has potential for assessing vascularity, which could offer predictive insights, though that's still evolving.
What about ultrasound?
Ultrasound is an emerging tool, gaining traction. It's cost-effective, radiation-free, so it's promising for monitoring healing and detecting early callus, particularly in non-operatively managed cases. It offers a dynamic view, too. For evaluating biological activity, especially in atrophic or non-hypertrophic non-unions where you suspect biological dormancy, nuclear bone scans, often SPECT, single photon emission computed tomography, can be useful. These scans help assess metabolic activity.
Looking for hot or cold spots?
Essentially, yes. Photon-deficient cold areas might guide a decision towards autologous bone grafting, indicating poor blood supply or biological inactivity. However, their sensitivity can vary. Some studies show sensitivity as low as 50% for atrophic non-unions, so they must be interpreted in the full clinical context.
Then finally, blood tests.
Absolutely. Laboratory evaluation is essential. We routinely check inflammatory markers, CRP, ESR, WBC count, to help rule out infectious processes, as occult infection is a major cause of non-union. We also assess underlying medical conditions, total protein, serum albumin for nutritional status, vitamin D levels, remembering that deficiency is incredibly prevalent, maybe 60–70% in non-union patients, and thyroid, TSH, and parathyroid PTH levels, as endocrine issues impact bone metabolism. These tests help identify systemic factors that might be impeding healing and need optimizing.
That's a truly comprehensive diagnostic pathway, Professor, pulling together clinical acumen, detailed history, and a whole suite of imaging and lab tests. It really underscores how complex these cases can be. Once diagnosed, Professor, what are the current best practice strategies for managing these challenging non-unions? From non-operative approaches to the most advanced surgical techniques, how do you tailor the treatment to each patient, effectively applying that diamond concept?
Right. Once we have a clear diagnosis and a thorough understanding of the non-union's characteristics identifying which diamond concept pillars are deficient, the management truly becomes a multifaceted and highly tailored approach. Our overarching goal is always the same: achieve a pain-free, healed bone with maximum functional recovery for the patient, and do so as efficiently and safely as possible. We often start by considering non-operative treatment for select cases. This might be appropriate for very early delayed unions, or perhaps if surgical risks are prohibitive due to the patient's comorbidities. These approaches include prolonged immobilization, using a fracture brace, cast, or splint for an extended period, trying to provide that missing mechanical stability, hoping to encourage biological bridging, often a first line for very stable or small bone non-unions perhaps.
Giving it more time and support.
Essentially, yes. And then there's external bone stimulation. This is a key non-operative modality you'll see used. Devices deliver low-intensity pulsed ultrasound, LOCU, or pulsed electromagnetic fields, PEMF. Libius, for instance, works by stimulating bone growth through mechanotransduction. It increases the expression of various cytokines and growth factors, including BMPs and VEGF, promoting angiogenesis and osteogenesis. It might even have some antibacterial and anti-inflammatory effects.
How does it work?
We've seen high union rates reported, ranging from 70% up to 93% with ultrasound in some studies, with generally better outcomes if it's applied relatively early, typically less than 6 months post-surgery. However, it's not a panacea. Contraindications include things like synovial pseudoarthrosis or a large fracture gap, usually over 1 centimeter, where the mechanics are just too unstable.
Okay, so non-operative has its place, but often surgery is needed.
When non-operative methods aren't sufficient, or for more severe established non-unions, we almost invariably move to operative treatment. This is where the diamond concept truly comes into play. We meticulously aim to address its core requirements, achieving robust mechanical stability, fixation, and enhancing the biological milieu, grafting stimulation.
Tailoring it based on the classification.
Exactly. For hypertrophic non-union, the primary goal is straightforward. Dramatically improve mechanical stability. The biology is active, the problem is movement. Techniques include applying compression plates to bring fragments together rigidly, or exchange nailing, particularly for long bone diaphyseal non-unions like the tibia or femur.
Taking out the old nail and putting in a bigger one.
Precisely. Removing the existing intramedullary nail and inserting a larger diameter or sometimes longer nail significantly improves stability within the canal. It can also stimulate healing by reaming the canal, introducing some biological factors. This is generally preferred over simple dynamization, especially if there's comminution or a persistent gap, as it offers a much more robust mechanical solution. Other options include augmented plating with ORF, adding extra plates or screws, or sometimes even surgical excision of the hypertrophied zone before applying new stable fixation.
And for the atrophic type, where biology is the problem.
For atrophic non-union, this is where it gets more challenging, as we must address both the poor biology and the inadequate mechanical stability. This often involves aggressive internal fixation combined with vigorous biologic stimulation. The biological stimulation options are diverse. Bone morphogenetic proteins, BMPs. Specifically, recombinant human BMP7 is approved for tibial non-unions, and ARGBMP2 is widely used for spinal fusion and shows significant potential for inducing bone formation and angiogenesis at non-union sites. They act as potent osteoinductive signals.
Directly stimulating bone growth.
Yes. Then there's autologous iliac crest bone graft, AIBG. This remains the gold standard for many because it provides all three essential properties: osteoinductive growth factors, osteoconductive, a scaffold, and osteogenic living cells. However, we must always consider and manage donor site morbidity, pain, infection, nerve injury potential.
What are the alternatives to iliac crest graft?
Intramedullary reaming, irrigation, and aspiration, RIA, is an innovative technique. It lets us harvest large quantities of rich medullary bone graft from within the fractured bone itself, offering a valuable source of MSCs and growth factors, often comparable to AIBG, but from the same surgical field, avoiding a second incision. Demineralized bone matrix, DBM, is another option. This processed bone allograft provides an osteoconductive scaffold and retains some inherent osteoinductive growth factors, often used as an extender or substitute for autograft. And we can also consider systemic parathyroid hormone, PTH therapy, teriparatide. It's an anabolic agent stimulating bone formation systemically, sometimes used as an adjunct. Plus, local debridement of non-viable bone ends and modifying existing implants are crucial steps.
Oligotrophic is a mix of these.
Oligotrophic non-union often requires a blend, yes. A combination of internal fixation to improve mechanics and biologic stimulation, tailored precisely to the clinical situation and the degree of biological deficit.
And the septic ones, the infections.
The most challenging category by far is septic non-union. Infection eradication is the absolute priority before robust bone healing. The gold standard here is typically a two-staged surgical treatment protocol.
Stage 1 focuses on cleaning things up.
Exactly. Stage 1 involves meticulous removal of all loose or infected hardware, thorough debridement of all infected and devitalized soft tissue and bone, revision fixation to stabilize the limb, and immediate application of culture-specific, local, and systemic antibiotics. This might involve antibiotic beads, antibiotic nails, or antibiotic cement spacers, delivering high concentrations locally. If there's significant bone or soft tissue loss, we might use the masculinate technique, apply external fixation, and involve plastic surgeons for flap coverage. The aim is a clean, viable, infection-free environment.
Then stage 2 for reconstruction.
Stage 2 is performed after a period of antibiotic therapy, typically weeks or months, once inflammatory markers like CRP, ESR, WBC have normalized, and clinical signs of infection are absent. It involves definitive fixation, internal or external, and then bone grafting, other biological treatments, or even bone transport techniques depending on the defect. This phase aims for stable bone union in a sterile field.
Are there other advanced techniques emerging?
Yes. Beyond these classification-specific strategies, there are various advanced techniques and technologies. Vascularized bone grafts. For cases with significantly decreased blood supply, perhaps due to trauma or prior surgeries, these are superior because they bring their own intrinsic blood supply, accelerating healing. Common donor sites are the fibula or iliac crest. Exchange nailing is mentioned, very effective for aseptic diaphyseal nonunions, and newer antibiotic-coated intramedullary nails are now available for septic cases, integrating infection control with stability. Extracorporeal shockwave therapy, ESWT, a non-invasive option using high-energy sound waves to stimulate healing-enhancing angiogenesis, growth factor expression, osteogenesis, gaining acceptance as an adjunct orthobiologics. Beyond BMPs, platelet-rich plasma, PRP, is gaining attention delivering growth factors and cytokines from the patient's blood. Mesenchymal stem cells, MSCs, from bone marrow or adipose tissue are also promising due to their differentiation potential and ability to suppress fibrosis, although clinical evidence and standardization are still evolving.
And looking further ahead.
The horizon is exciting. Things like gene therapy, introducing BMP or VEGF genes directly, tissue engineering, custom scaffolds seeded with cells, advanced stem cell therapy, and even 3D printing for patient-specific implants to provide precise stability and promote regeneration, tailored exactly to the patient's anatomy.
Professor, it's clear that there's no single magic bullet for non-union, is there? It's rather a carefully orchestrated, multi-pronged plan for each patient, meticulously tailored to their specific non-union type and underlying deficiencies, a true reflection of applying that diamond concept in practice.
Exactly. And the success of the diamond concept, when rigorously applied, is truly compelling. Studies where all 6 principles were fully addressed report union rates as high as 89–100%. That's exceptional for such challenging cases.
Much better than when only some aspects are addressed.
Significantly, it contrasts sharply with lower rates, often between 44% and 90%, when fewer elements were augmented. It's a powerful testament to taking that comprehensive approach. We've also learned the importance of things like bone marrow aspirate concentrate, BMAC, for providing a reliable, concentrated source of MSCs, particularly perhaps in older patients where iliac crest sources might be less potent or where the RIA process might inadvertently wash out some MSCs. It's about truly understanding and addressing every facet of the healing environment for each unique patient.
That's a powerful statement about the diamond concept, Professor, showing that when we truly understand the pathophysiology, our treatments become far more effective. Now, as we approach the conclusion of our deep dive, let's turn to outcomes. What's the outlook for patients with non-unions, and what are the potential pitfalls or indeed the profound human element we must counsel them on?
The prognosis for non-union can vary significantly, as you'd expect. Depends on the type, the patient's health, the intervention chosen. For non-operative treatments like ultrasound, we can see quite high union rates, 70% to 93% reported, which is encouraging for select cases. Similarly, surgical treatments often boast high union rates. Nail dynamization around 83%, humeral shaft exchange nailing maybe 95.6%. These are good numbers for inherently difficult problems.
But infection changes things dramatically.
However, it's crucial to understand that infected non-unions present a much poorer prognosis, significantly lower union rates despite aggressive, multi-staged intervention. The presence of infection fundamentally complicates and compromises the whole healing process.
What about complications of treatment?
In terms of complications, several can unfortunately arise, both from the non-union itself and from our interventions. We sometimes see nerve injury, like the radial nerve in humeral shaft fractures, during exposure or fixation. The persistence of non-union is, of course, a primary concern, which in severe recalcitrant cases, particularly in the lower limb, can tragically lead to the eventual need for amputation if all other options are exhausted and quality of life is severely impacted.
And infection remains a risk.
Infection itself is a major complication, capable of causing further tissue damage, implant failure, prolonged morbidity. Surgical site infection rates can range from maybe 1% in low-energy closed fractures but soar to over 30% in complex high-energy open tibia fractures. It underscores the severity. Furthermore, specific complications are linked to certain biologicals like BMP2 osteolysis, heterotopic bone formation, wound issues have been reported, and the complex interplay of deep bone infection and fracture healing failure in infected non-unions necessitates very strategic, difficult approaches to treat fracture then infection, infection then fracture simultaneously, or unfortunately sometimes amputation. It's a truly difficult pathway for everyone involved.
Beyond the purely clinical and surgical outcomes, Professor, there's that profound human element to non-union, isn't there? The patient's journey must be incredibly challenging, affecting so much more than just their limb.
Indeed, the human element is absolutely paramount and something we must never lose sight of. Non-union imposes a substantial burden that extends far beyond the direct medical costs. For instance, in the U.S., the median cost of treating an open tibial non-union is estimated at over $25,000 USD, double that of healed fractures. But this is just the tip of the iceberg. The indirect costs, loss of productivity, prolonged functional impairment, loss of income, need for ongoing care are often the key drivers, sometimes reaching far higher figures.
It affects their whole life.
Profoundly. Patients with non-unions experience significantly worse physical and mental health. They report increased chronic pain, severe limitations in function, and disturbingly higher rates of early retirement and unemployment, particularly with femoral non-unions, which impact mobility so dramatically. Lower limb non-unions in particular are strongly linked to increased morbidity and considerable damage to physical, emotional, and mental well-being. Sadly, including reports of low mood, anxiety, even suicidal thoughts in some studies due to the chronic nature of the problem and its devastating impact on their lives. It's a truly debilitating condition.
Which highlights the importance of communication.
Absolutely. This underscores the necessity of thorough patient education and shared decision-making. We must counsel patients meticulously on all possible outcomes, including the realistic chance that a fracture may not heal even with optimal treatment. Being transparent and involving patients in these complex decisions enhances rapport, reduces confusion, and can also mitigate the likelihood of dissatisfaction and, regrettably, litigation. It builds trust and manages expectations.
And the need for a team approach.
Finally, to truly enhance outcomes and provide the best care, an interprofessional team approach isn't just beneficial, it's absolutely crucial. This team should ideally include orthopedic surgeons, of course, but also dedicated physical and occupational therapists, indispensable for functional recovery, infectious disease experts for septic cases, vascular surgeons if needed, plastic surgeons for soft tissue coverage, and specialist wound care nurses. Nurses play a vital role in monitoring wound care and ensuring effective communication across the team and with the patient. Furthermore, integrating psychological support and enabling early detection of psychiatric distress is essential. Their mental well-being is just as important as their physical recovery. Ultimately, our treatment strategies must aim not just for bony union, but to reduce healing time and facilitate a rapid return to activities not only for medical benefit, but also to alleviate that profound financial and psychosocial burden on our patients.
Professor, what a deeply informative and, yes, often sobering discussion on bone non-union. We've really covered the ground, from the intricate biological processes at play right through to the real-world implications for patients and the comprehensive, tailored approach required from us.
Well, as we consider the future, the ongoing advancements in orthobiologics, gene therapy, 3D printing, they continue to push the boundaries, don't they? Offering exciting new avenues to restore bone integrity and significantly improve patient lives. It really raises an important question for all of us in the field, I think. How can we best integrate these cutting-edge innovations into everyday practice to address this persistent challenge more effectively and ensure they actually reach every patient who could truly benefit?
A truly thought-provoking point for us all to consider as we look ahead. Thank you, Professor Moimam, for sharing your invaluable expertise and insights in this deep dive ortho. If you found this discussion valuable, please do consider rating and sharing this deep dive with your colleagues. It helps us reach more orthopedic professionals like yourself. Until the next deep dive.